All right, we're going to have to wait for the delinquent children to come back in. Obviously, people have been spending a lot of time away from, having actual human contact, so can't really draw themselves away from coffee and tea and cake, I'm assuming. So I've got the pleasure of trying to host you for the last session of the afternoon and keep you entertained. And we're trying to, so what we'll do is we'll really be as interactive as possible, and we'll have some interaction both for the people on the here with us live, but also for those of us who are joining online. So we're going to have 2 case presentations, and in between those case presentations, we will have we'll post some questions onto the online group, and they can answer it, and while we're asking our panelists for their response to those questions. So first slide. Yeah. So I'm Mo Archery, before I forget to tell you who I am. So I'm from Durban. I'm a pediatric infectious disease specialist, and we'll go through these 2 interesting cases really around difficult management issues in pediatric HIV. So we really have a range of people from across the world. So our 2 case presenters is Sibongiseni Malinga. He's from Durban, South Africa. He's joining us virtually. It's now, I think, 11 o'clock at night. So we're very lucky to have him still awake and being able to present. And in person, we got Michael Hawkes, who's from the University of Alberta, Canada. And then we have our esteemed panelists. So Sharon, who you know and have seen before. Anna, who you know and seen before, I think. And then Renata Strato from South Africa, who's going to join us and give us a South African perspective. Unfortunately, Brian is unable to join us today, and he's had some visa issues, so he'll be from outside of the airport. So we're going to go through the first case, and I'll hand over to Sibu to go through the first case, and I'll just click next after each slide.
Greetings. Can you just confirm if I'm audible?
Yeah, we can hear you.
Thank you. It's quite an honor to be part of this workshop, and I'm quite grateful. The title of the case is Breaking the Unbreakable. So our index patient is a 13-year-old male from Umzinyati, rural area in Durban, who was born to a teenage mom. So mom did not have a complicated pregnancy, normal birth history, delivered a term appropriate for gestational age. Mom had tested negative during pregnancy. However, the test was not repeated at birth. In terms of medical history, the diagnosis of HIV was made when the patient was admitted in 2010 for pulmonary TB at the age of 16 months, for which the patient completed 6 months of TB treatment. The patient was also started on abacavir, lamivudine, leponivir, ritonavir syrups 2 weeks after starting the TB treatment. It is unclear if the patient received ritonavir super boosting during the course of TB treatment. The mother was also started on antiretroviral therapy around the same time. So there are a lot of social circumstances that were impacting on his adherence. Wandile was born after his mother was raped by an older cousin while she was visiting her uncles. The maternal grandmother was unaware of this rape until 2 years ago. So the mom was the primary caregiver at the time under the supervision of the grandmother and would be the one to bring the patient for appointments at the ARV clinic. So the biological father will also bring the patient to the ARV clinic, but I only identified himself as the patient's uncle as he was the mother's cousin. So this slide basically looks at the patient's age, weight, as well as CD4 and viral load. So the available blood results were only from 2014, unfortunately. And of note is that at no point in time did the patient ever have 2 consecutive viral loads that were less than 1,000. So at the time, he was on abacavir, lamivudine, and leponova-ritonavir syrup. So unaware of the issues around rape, when the biological father of the patient, started getting ill, the grandmother invited him to stay with their family. So this, as a result, caused the mom to go missing from time to time as she was avoiding confrontation with her alleged rapist. So in 2018, the patient was assessed as having virological failure and a genotype was done. Around the same time, it was also noted that there was a lot of conflict between the biological mother of the patient as well as the grandmother. So in terms of the genotype results, only the 184V mutation was selected, conferring high-level resistance to lamivudine and MBChB, as well as low-level resistance to abacavir.
So what we're going to do is we're going to get some clarity from so we're going to open up some questions to the online audience, and then maybe you can start from the extreme. So Anna, so what do you make of this drug resistance profile? I mean, he's been failing for years on a leponova-ritonavir based regimen and only has a 184.
Yeah, I'm actually wanted to ask whether do you think it's reliable resistance? The problem with the resistance test, it's only reliable when you do it. There is a drug pressure. So it looks like this child, hasn't been taken, antiretrovirals for a while, and his viral load is 64,000 plus, with CD4 going down. I really doubt that there was any, maybe very little drug pressure, if at all. So what drug resistance shows kind of no resistant mutations except M184V. Which I don't think is reassuring. I don't really believe this resistance test. And that is the problem with the resistance test. You need to do them with the drug pressure on board, otherwise they are not informative.
Yeah, so I think maybe just to reiterate, I think it's the drug resistance test, although we put so much of emphasis on it, only tells you a snapshot in time and may not give a full picture of what exactly is happening.
So I wanted to add one comment that I wonder if it's actually correct in that there's no other resistance because he hasn't taken any meds at all. So it may be that when we think about these, do we automatically switch and assume there was resistance but we don't know about it? Or do we automatically say, we're going to recycle those drugs and really see what happens? I always worry that when we see some resistance or we have someone that's not adherent, we sometimes say, it's a failure and go ahead and switch, when in fact we need to take a step back and say, if you failed already, you have resistance, it's worth it for me to try a month or 2 months of better adherence using the exact same regimen before I say, I have to toss it out.
And so maybe just to add, so the online audience agrees. They say 67% of them said that they don't think the resistance test is an accurate reflection of what the underlying resistance in this patient. So one of the suggestions is, and we'll come to maybe then this in terms of the regimen for this patient, is around just changing to a 3 NRTI regimen and not the PI, or he's only taking his NRTI. Okay. Yeah. So the other alternative is he's not taking the leponova-ritonavir, and that's driving just the NRTI resistance.
You would probably expect if he was doing this like some abacavir kind of mutations as well. But I just wanted to discuss what regimens would you recommend. And I do agree with Sharon because he's on lopinavir, ritonavir, abacavir 3TC. In 2018, I don't think the lutagravir was around, isn't it? No. So it actually would be very difficult kind of, this chap probably would mean that you would only be able, if you switch anything as a Bacavir to Zidovudin, you kind of like, you know, don't really win a lot. So I probably would, if 2018, I would be leaving Lopinavir, Ritonavir, Bacavir 3TC, and doing adherence counseling and probably repeat viral load in, you know, 3 months' time, plus minus resistance, etc. But if we are currently thinking we are in 2022, and he is at 25 kilos on the previous slide, with a viral load of 69, 25 kilos, you can actually take dolutegravir. And I would really want to give this kid tenofovir, but, you know, it's in UK, we may just like find tough FTC, but in low middle income countries, the TDF is only eligible, like, you know, you can give it in children of 30 kilos plus. But looking like, you know, previous TDF toxicity when we were discussing this, it's usually we see it with PIs. And I just wonder, like, you know, whether 25 kilos, they're growing quite fast. They're gaining 2 kilos every year. Is it that bad to give tenofovir a bit earlier? And then you can have TLD, small tablet, once daily. Would it be nice to just like, you know, this is can give you very good supportive adherence, like, you know, and easier to manage?
So one of the online audience kind of were split. So some of them said using a 1 tablet once a day, which would probably be TLD. And again, at 24 kilograms, tenofovir is a bit of a stretch. If you'd use a milligram per kilogram, I think at the worst case scenario, you probably can go down to 28 kilograms, but I think 24 is a bit much. And then,
He's 25.
and then 60% said 2 tablets, and I'm assuming that they, you know, we're trying to go ahead in time and really go for a dolutegravir-based regimen. So
I'm going to put a spanner in the works here, because working in a similar, well, in this environment, we have fantastic options, but they're very, very limited. And I would be, I think, the clinician at 69,000 not to change anything at this stage, because there are, we can see the multitude of social problems that we first need to, I was going to say fix, we're not going to fix them, but attend to them in order to get any kind of improved adherence. Yeah, and I mean, there's already been TB in the family, and now the father presents ill in the household. But even with all of that, the kind of family strife, clearly with 69,000, there's very little drug being actually taken in. So you would first have to address that and see then what you would have available as potential treatment options.
So let's just go on with the case and let's see what happened. Sibu, back to you.
So this slide looks at the continuation of what happens in terms of the viral load. So at the face of it, when we saw that the patient only had selected the M184V, was changed to second line AZT3TC, and because there were no PI mutation at the face of it, we kept the patient on lopinavir, ritonavir. However, we changed it to tablets. So we had put him on the AZT3TC combination as he had a weight of 25. So we're looking at least 8 tablets a day that he had to take. So 1 AZT3TC combination and 3 pediatric tablets of the lopinavir ritonavir. So of note is that around 2019, earlier in the year, the father demised, and later in the same year, the mother also demised, both of them demising due to AIDS-related complications. So this further caused a complication in terms of his adherence, and at this point, the patient did no longer have, well, from the time that the father had moved in with the family up until now, the patient did not really have someone who was assigned fully to bring him to appointment. So from time to time, despite him receiving the drugs, but there was no someone to either observe him or actually take him to the clinic. So also of note was the grandmother had difficulty in accepting the second circumstances around the rape, and you sort of avoided being directly involved in the healthcare of her grandson. This was after she discovered that the patient was a product of rape.
Okay, so now we've got him at 11 years, 28 kilograms. His viral load is 529. CD4 count 274. So what would you do? So this is probably the lowest.
I said already what I was going to do. Like, so this is another chance to put TLD. The grandmother will love you because it's a small tablet once a day. That will make her care much easier.
Okay, so we'll break the guidelines and
not break them.
bend the guidelines.
Routine consensus.
And I think that's one of the things, especially as clinicians, we're often very comfortable with doing, is reading the guidelines and reading between the lines of the guidelines to see how our patients fit into the guidelines.
It's 28 kilos, nearly 30. Right?
Yeah, if you round it off. Yeah.
I think we really need to look back into TDF toxicity and review that data, because I do remember, given that presentation, a few years back when I just probably started, it was PI-based toxicity. Lots of kids were on PI plus tenofovir, and it does take quite a long time to develop toxicity. 2 years on a slightly higher dose wouldn't make any difference.
So I wanted to say, when I was thinking about this child and I was thinking about the growth chart and looking, and I had that history of TB in my head, part of me wanted to make sure that I'm not missing something. That is it possible that, we're doing all this ARV and blaming everything on non-adherence in ARV, but it wasn't clear to me, was the rest of the family assessed for tuberculosis? Were they reassessed for tuberculosis? And I hear that the mom died, and I hear the dad died, and I hear it was from HIV-associated, illnesses, but I kind of wanted to understand how often should you be looking for TB, and in a child that we know already had intrathoracic TB, how much should I look again for it and see what's going on? And I don't know that I have a simple answer for it, but I just wonder if we're focusing so much on one thing that maybe it's worth it to take a step or two back.
Yeah, so I think especially, when the child is deteriorating, where the weight is not improving or weight is actually decreasing, which is usually quite a sign that something is going wrong, and that you do need to look for opportunistic infections, whether it's TB or Cryptococcus or something else, especially with that low CD4 count, would be something that's interesting. And just to say, so the online audience was going with Anna and going with one tablet, which we're assuming is TLD. And then 20% said no single tablets are available. Sorry. Okay, sorry. Sibu, back to you.
So in January of 2020, patient had a weight of 28 and had a viral load of less than 1,000. So we decided to change and try and simplify the patient's regimen to AZT, 3TC, and DTG. So from a total of 8 tablets a day, we had reduced his pill burden to 3. So the AZT, 3TC taken twice a day, with dolutegravir only taken at night. So at this point, it was the patient's cousin, who was just 4 years older than him, who was accompanying him to the clinic. So this graph basically looks at the fluctuations between his viral load and CD4s from the year 2014 up until 2022. So the patient continued on the AZT, 3TC, DTG. Of note that in April, we had a viral load of 3,838. After that, there was no viral load that was less than 1,000. So in April of 2022, the patient was assessed as having virological failure on dolutegravir-based regimen, and a genotype was ordered. So in terms of the genotype, in terms of the integrase strand transferase inhibitors, The patient selected the 66I118R as well as the 138K mutations, conferring high-level resistance to all integrase strand transferase inhibitors, with an exception of bictegravir, which was only intermediate. In terms of the NRTI mutations, only the 184V again was selected.
So back to the, so unfortunately we changed him to AZT3TC dolutegravir and didn't listen to Anna. And so now we've got, so he's actually put on quite a bit of weight on dolutegravir. He's got no new NRTI resistance, but he's got, surprisingly, we were shocked at the result when he came back, that he had quite significant integrase inhibitor resistance. So what would be your...
May I just comment on this, on the resistance? Because, you know, zidovudin 3TC is given twice daily. 13-year-olds, they probably forget to take the evening dose. And it means that, like, you know, zidovudin and 3TC, the drug exposure is non-existent there. So actually you're given dolutegravir monotherapy. Not surprising, you know, there will be like insta resistance and you're losing the class. Unless you kind of really support the adherence of twice daily medication, it's, yeah, kind of a regimen of how do you say, risky. And so now currently you need to reassess and think about third line, isn't it? But I think, you know, it's very different what we kind of think low middle income countries, developing countries, and in the north. You know, in our multidisciplinary clinic, you know, my team will be jumping on this child and starting on probably darunavir, ritonavir plus tenofovir plus double dolutegravir, double twice daily. And it will be like, you know, third line, but with a lot of drugs on board. And I just wonder whether, you know, you can kind of think about maybe darunavir, ritonavir, and TDF. 3TC here.
Yeah, I think
once daily, yeah.
So I mean, ideally, what do you want to try to get? I mean, I think what he's shown us is that he can't tolerate, you know, twice daily treatment, and that you know, getting it down to a once daily treatment probably is going to be the best bet for this child.
Yeah, so I mean, at 13 years, we've all thought about disclosure now to this child, and the thing about what we thought when dolutegravir arrived in the scene in South Africa is that it was sort of the panacea, that we could, we wouldn't see these resistant patterns and we could start dolutegravir. And had we started that and this poor child had actually been adherent to his treatment, we still probably would have jumped on him and made him feel dreadful about not taking it, and he would be taking it. And then I agree with you about boosted darunavir, but it is accessibility. So it isn't that easy to access it. We would have to go through third-line committees and eventually get hold of it.
You know, I think that we could design the perfect or near-perfect regimen, but we actually haven't ever really fixed the adherence question. And, you know, when I see a 13-year-old being brought in by a 16-year-old, I'm assuming that everybody's talking about his HIV status and everyone's making him a social pariah at home. And I want to say that we're destined to fail that next regimen without actually fixing some of the home stuff. And unless the grandmother is going to be, anyway, I want to say brought up to speed or engaged in care, no matter what regimen you give him, it's still going to be a really difficult, a big lift.
Sibu, back to you.
So in terms of the patient's outcomes, the patient was referred to the social worker and a home visit was conducted to help deal with the social issues impacting on his adherence. And at this point, we were able to then bring the grandmother on board. So in May of 2022, the patient was changed to a once daily regimen, which was tenofovir, emtricitabine, fixed dose combination, and darunavir as well as ritonavir. So the patient is receiving ongoing enhanced adherence counseling, and the repeat viral load 1 month after switching to the once daily regimen was 473 copies with a CD4 of 407. Thank you.
Thanks, Ivo. So I think, again, it does, does indicate that although we think of dolutegravir as a panacea for all ills, but if it's abused, we will lose it. And certainly, I think in the context of a non-adherent patient or a intermittently adherent patient, which is probably worse off than a completely non-adherent patient, we are going to lose this, extremely important class of drugs, and we do need to be careful about how we move forward with that. So I think we're going to go on, thanks, Sibu, and we're going to go on to the next case, and Michael's going to take us through a neonate who's got a deadly duo of HIV and congenital syphilis.
Great, thank you very much. So my name is Michael Hawks. I'm pediatric infectious diseases from Edmonton, Alberta, in the western part of the country. I'm driving. All right, so this story, I'll just first of all tell you that Edmonton in Western Canada is a low prevalence, high income setting, unlike South Africa, high prevalence. So we see vertical transmission of HIV every 2 to 3 years, a single case every 2 to 3 years. And we follow 30 children living with HIV in total in a city of 800,000. So a low prevalence area. So welcome the panel's input on this case, which we're not super, so we don't get every day. So the story begins with the mom, 29-year-old woman living in a homeless shelter with 3 previous children who are all in foster care, and a history of methamphetamine substance use disorder and psychosis. And you can see there on the slide, there's multiple ER visits during her pregnancy. She didn't access routine obstetrical care, but she did come to the emergency several times for various complaints. The first time, dating it, retrospectively dating it back to around 8 weeks gestational age, she came in with a vulvar lesion and some non-specific complaints. And that was the visit at which they did a beta HCG and diagnosed her pregnancy, okay? So a week later, she presents to a completely different emergency department, this time, recognizing her pregnancy test. They do an ultrasound which shows a viable 9-week fetus. At this point in time, they do a syphilis serology, which is positive. The result, however, isn't available until several days later, and they're unable to reach her. She doesn't have a telephone number on the chart. So they call public health, notify public health of this case of syphilis in pregnancy. Around 20 weeks gestational age, she spontaneously comes back to emergency, this time with a diffuse rash is her complaint. And it's quite itchy, it's thought to be scabies. She's chlamydia positive at this point in time, and recognizing her past syphilis positivity and her chlamydia, the emerge doc wants to give her some treatment, but she leaves against medical advice prior to getting any treatment for her syphilis or her chlamydia. Finally, public health tracks her down at the shelter, and she's hospitalized at around 28 weeks of gestational age. And this is the hospitalization during which she has some testing done for HIV, which shows for the first time she's HIV seropositive, in addition to the syphilis untreated during pregnancy. So during this hospitalization is when definitive management of the pregnancy was done. And so, but just before we get to the delivery here, just to summarize her HIV and her syphilis in pregnancy, she had a viral load of 140,000, just diagnosed at that hospital admission, and that's going to be 2 weeks prior to delivery. And she had negative serology back in 2021, so this is a seroconversion in the past 18 months or so. And she was treated with bictegravir-based regimen beginning 12 days prior to the delivery, no follow-up viral loads before delivery. The syphilis, it sure sounds, if you put the story together, this was primary syphilis during the pregnancy. She was seronegative for syphilis back in 2021. She had presented with a vulva lesion, possibly the primary chancre, and then later presented with a diffuse rash, which was maybe the secondary syphilis. And then her first serology done at 9 weeks gestational age was 16 dilutions, 1 in 16, went up to 1 in 1,024 dilutions by 28 weeks gestational age without treatment. And like I say, she was admitted to the hospital at this point in time, and they treated her with intravenous penicillin rather than benzathine, weekly intramuscular benzathine penicillin. They opted for an intravenous regimen to really definitively try to treat both mom and baby. I just wanted to take a quick aside to mention a syphilis outbreak in Western Canada. I'm not sure if people are aware of this, but we have a 500% increase in the rate of syphilis in women of childbearing age, and that's affecting mostly Alberta, where Edmonton is, and as well as Saskatchewan and Manitoba in the western provinces. And this has resulted, the sharp rise in syphilis cases in women has also resulted in congenital syphilis. We've had 170 cases and 35 deaths since 2015. So the deaths in this age group outnumber the COVID deaths. Okay, so this is a worse outbreak among the neonates than COVID, if you will. So coming back to our patient now, mom's admitted to the hospital. Maternal and fetal medicine is going to come do some ultrasounds, and what they find is that the baby's starting to get sick. Cardiomegaly, ascites, pericardial effusion, high output failure. Looks like anemia with congenital syphilis and an evolving hydrops fetalis, non-immune hydrops fetalis. So decisions made to deliver the baby early, and the baby's delivered at 30 weeks of gestational age, and ICU is involved. They give some steroids for lung maturity. Baby's delivered by C-section under general anesthesia, and APGAR's okay, but baby does need some cardiopulmonary support given the prematurity, with initially some mask ventilation proceeding to CPAP and then on to intubation. And a dose of surfactant given. Birth weight's on the 60th percentile and head circumference on the 50th percentile. And IV zidovudine is given in labor because you'll recall that the serology was positive, known to be positive just 2 weeks prior to this. Early in the NICU course, baby's intubated and ventilated with lines, and the congenital syphilis is treated definitively, again, with IV penicillin in the baby this time, 10 days. And the baby needs lots of transfusions. The baby has marked anemia, so needs RBC transfusions as well as platelet transfusions. And the baby's kept NPO because of the prematurity and actually has signs of intestinal dysmotility with bilious emesis. And so this is the point at which they call PEDS ID and they say, what should we do for the baby for HIV prevention at this point in time, you see, because mom is seropositive. We don't know what the baby's status is. We've sent off a viral, we've sent off a proviral DNA PCR, but we don't know if the baby's infected or not.
So maybe to the panels, do you want to, what would you, Sharon?
I just want to make sure that it was Friday night at 3 o'clock in the morning.
That's right.
So I just wanted to make sure it's not just the New York experience when that happens.
Yeah, no, you're right. That's exactly what it is.
I think that, we're going to hear a talk tomorrow from Tim Cressy about PKs in the young babies, and we've had a lot of people trying to look at stuff. I think that obviously the monotherapy with AZT is probably not the right answer, and I think you're kind of stuck in that. Good news, you can use IV AZT, but this is a baby that's incredibly high risk. And we need to think about, what medications we can do. And I appreciate that the baby's gut is not moving so much. But on the other hand, this kid is probably only going to get a once-a-day med anyhow because they're not going to metabolize it so much. So I wonder if it would be reasonable to go ahead and give a single dose of some of the other medications. What do we have data on? There's not a whole lot of data in this age group to start with, and the baby's so young, so metabolically not so smart either. But I think that IV AZT alone isn't going to win.
So maybe just to say, so the online audience is going 75% for a triple regimen using IV AZT with the intro 3TC and nevirapine.
Yep. That's so.
Anna?
Can I just add, but you have to really think about necrotides and enterocolitis, isn't it? If the baby that's sick doesn't tolerate any enteral fits, you don't want to kind of like have a necrotides and enterocolitis on top of what you have already, and then you have to stop all the feeds and stop all oral drugs and etc. So though I'm just like really want to give triple prophylaxis in this case, be very careful and maybe just try to make sure that like at least minimal feeds are tolerated before starting 3TC and nevarapine.
Yeah, I mean, certainly I think if there's evidence of NEC, you're probably not going to start it, and you probably will. But I mean, I think if they often will have feed intolerance, then you probably can get away with small volumes of liquid.
There is.
But that's, there's so many of them that have bilious spasms, poor motility, not HIV related, I'm just talking in general. And what we do is we continue on with continuous feeds and a small volume and increase very slowly and put them on TPN, but do like trophic feeds. So if it's neck, you're in trouble because then you really can't feed. But if it's not neck, go for it. That's what I would say.
Alistair? Yeah. Would you scream and then I'll repeat?
So, yeah, really challenging case, and I think that this isn't a criticism, but I would have liked to have got the call 2 weeks before the baby was about to be having the planned cesarean section, because what's really essential here is a birth plan that's written in the notes so that Sharon doesn't get the call at 3 a.m.
3 a.m.
They've already started the plan.
Which never
There's
happens.
things that we can do to load the baby before they're born.
Right.
And so double-dose tenofovir, single-dose nevirapine to the mother that can be given at the time that you're planning the delivery. And then if the baby doesn't tolerate any feeds, you've got drugs on board already.
Right.
And I'm not sure about the data for Biktarvy and crossing the placenta, if there is any, but I'd be tempted to give something that we know is going to cross the placenta like dolutegravir.
Right, I agree 100%. You know, we all want to have the heads up when the mom is sitting there with her syphilis, with the baby, with the high drops. But I'm going to say politely, we all know that Friday night, 3 o'clock in the morning is when we actually get the call. She's been sitting there, and now we delivered her. But I do think that the planning, and we're all unfortunately seeing these women who are, I want to say, outside the system coming in with surprises, that talking to our OB colleagues is probably the most important thing we're doing now.
Okay, so let's move on, otherwise we'll run out of time.
Yeah, I just wanted to emphasize the high-risk scenario that we were dealing with, your high-stakes scenario. And this is an exhaustive literature review, but at least 4 papers will point to the fact that syphilis increases your the risk of intrauterine transmission of HIV. So study from early on in the epidemic in the US, as well as Malawi, Brazil, and multiple sites there. So looks like we had a high-risk scenario. The syphilis inflamed placenta probably going to exacerbate or increase the risk of vertical transmission in utero. So what we did is kind of what the team had kind of mentioned, that we definitely gave IV AZT. We dripped in slowly introduced some of the enteral meds, but already by day 2 we had a positive HIV viral load on the baby, so it became no longer a matter of prevention, but now of treatment. And in fact, we breathed a sigh of relief, right? Because the window, the golden opportunity has closed to us, but we have some breathing room. So 4.3 million copies per ml, and here's the proviral DNA came back positive at a later time point. It's HIV-1 subtype B. And here's the resistance testing. I've just highlighted the 3 drugs that we chose to use. It was pan susceptible, by the testing. And I just little footnote that the mum's resistance testing was also pan susceptible. And another little footnote that we did do the genetic testing for HLA-B 5701. So abacavir was not present. So abacavir was an option. You can see there another option on the list there would be raltegravir. I'm just highlighting those particular ones since those were the limited options we had available to us in the neonatal period. Just to quickly tie up the syphilis piece, although it's going to really be a problem for us as we manage the HIV. The infant's RPR was 64 dilutions. You'll recall the mum's was 1,024. Treated with IV PEng. The baby had high drops, had physical evidence, physical exam findings suggestive of high drops, had hepatitis, had anemia and thrombocytopenia. And I'm going to go into those ones in a little bit more detail because they challenged our HIV management. Lumbar puncture on day 28 of life. Once the platelets had improved and once the baby had stabilized, we delayed the lumbar puncture until that time. Did show high protein and reactive FTA ABS, possibly suggestive of neurosyphilis, although the white count was pretty normal and the VDRL was negative. Ultrasounds of the brain on all those time points showed some mildly prominent lateral ventricles, but no evidence of IVH. And we were working on getting an MRI done. Ophthalmology came to look at the eyes, no signs of syphilis in the eye, but there was some retinopathy of prematurity. And here's just the nice picture of his long bones showing the distal femoral irregularities and lucencies suggestive of congenital syphilis. Okay, So the first challenge we ran into in terms of his HIV management and how the syphilis was impacting the HIV management was, how do we dose these meds? And there were a couple of sub-elements to that, like what do we use for the baby's weight? Because there's a lot of extra fluid on board here with high drops and the secondary to the congenital syphilis. I'll remind you that the fetal monitoring had definitely documented that, and postnatally the baby had cardiomegaly, although there was good biventricular function. And ultrasounds had shown that there was some trace of perihepatic, perisplenic, pericardial fluid, some abdominal wall anasarca. So the baby looks fluid overloaded. Beyond that, we had an early gestational age that was even below the limit of the authoritative guidelines like AIDSinfo.gov, where they go down to 32 weeks gestational age for suggestions for these doses, but we have a 30-week prem. And then, of course, this gut absorption issue that we've already discussed. So I'll just quickly show you here the cardiomegaly. This is impressive, right? So day 1 of life versus day 16 of life, you can see his heart huge on the cardiothymic shadow it demonstrates very nicely the cardiomegaly, which resolves after treatment of the syphilis and appropriate fluid management by day 16. And the question around the weight, what weight do we use for the dosing? Well, here's his growth chart, and he ultimately stabilizes out around the 10th to 50th percentile, right, for weight. At birth, he's looking around the 50th percentile, and do the math. It's actually a fairly big. It's like 20% difference, right, from where he is at birth weight to where he ultimately settles, if we extrapolate backward on the growth curve, for what it's worth. So. I'll actually just move on because I have another question for the team. But what we did is we just adjusted his doses of the AZT, the 3TC, the nevirapine, based on his measured weights. And as you can see, it kind of stabilized around the 10th to 50th percentile, recognizing that volumes of distribution may be unpredictable in the edematous infant. And we used the recommendations for a 32-week infant, given in the AIDSinfo.gov guidelines, and we checked the drug levels for nevirapine. We didn't have therapeutic drug monitoring available for all of these meds, but at least we had nevirapine that we could check, and it was above the recommended trough of 3,000. So just summarizing a complex sort of dose escalation increment according to guidelines, he started off with IV zidovudine, switched to oral with a dose escalation there around 8 weeks of age. And this is pretty much according to guidelines there. 3TC with the oral regimen, escalating the dose, and nevirapine starting at day 2 of life and escalating. So you can see at the top there of my timeline the viral load at 4.3 million. We did, success. I think successfully brought it down to 6,700 by 4 weeks of life. With this regimen, and the nevirapine level you can see down below, checked at around 3 weeks of age, was therapeutic. So, I didn't have a question for the panel, but I'm going to get to another question. This is another interesting challenge that arose. And one is the liver enzyme abnormalities. So the congenital syphilis can do this to you. Here they are here. We're looking at, on the left, the hepatocellular enzymes AST, ALT elevated, the cholestatic enzymes alk-phos and GGT elevated, and the total and conjugated bilirubin elevated. And you can see that as over time in this baby. Clinically, the baby had bronzed skin, and they were giving ursodiol to inhibit hepatic synthesis of the bilirubin. So I just wanted to, again, quick question for the team. We have elevated liver enzymes in this sick neonate. We have them on nevirapine. Is this a bad idea?
Yeah, I mean, again, I think just to highlight that issue of syphilitic hepatitis, which is, it really does persist beyond the period of treatment, and it may actually be an inflammatory response, to dead organism. And it can persist for like weeks after you complete the penicillin. So how do you deal with it? And are you looking?
Yeah, I had a question first. Did you demonstrate that the titer from the syphilis came down? Because sometimes I worry that we need to do a second round of treatment on a kid like this.
We did not. We were planning around the 3-month mark, right, to repeat the syphilis.
Yeah, I was thinking I would have done it. He's already out. How many weeks out? I would have probably done it at something like 1 month, or even pushing me maybe 6 weeks, Because I'm really wondering, I hear what we're saying about the hepatitis and the drug comorbidities, all the other stuff, but I'm kind of curious to make sure that his titer actually came down to, 1-to-1 or something like that.
And it's often quite difficult because they don't come down that quickly. And sometimes, I think we've actually, initially what we used to do was persist with the penicillin for beyond, 10 days. And there's no evidence. There's, if you go back in the literature from 1950s, you'll find a few case studies, but nothing else
I just
beyond that.
wonder, with the CNS stuff, I kind of wonder if we needed to give this kid a repeat titer at maybe 4 to 6 weeks or 6 to 8 weeks, pick your number. And if it's not low, maybe some of the hepatitis, as you say, maybe, from the original syphilis, but maybe we're missing something.
So just to say, the online audience was 67% for continuing nevirapine, and so they, kind of want to continue.
Can I say so access to raltegravir in our setting would be difficult, and hands are pretty much tied that we would more than likely continue the nevirapine.
Yeah. So we're gonna,
Oh, sorry. I just thinking I would be, access to raltegravir is difficult. That's a different question. But nevirapine is known to cause liver toxicity, and sometimes drug-induced liver injury also can present with some sort of element of obstructive jaundice. So you can see this pattern with increased ALP and gamma GT. So though I think it is probably syphilitic hepatitis, kind of like nevirapine was just increased, isn't it, around that kind of 4 weeks, isn't it? You doubled nevirapine, and then you saw kind of increase of ALT. I'm just trying to be provocative, but, I don't like nevirapine and hepatitis, so I would like to change to raltegravir.
Okay, we're going to run out of time.
I'll just quickly finish this because I just want to show you this. So we have this is not our patient, but we're getting more and more experience with severe congenital syphilis with our outbreak in Western Canada. So in just reiterating exactly what Mo said, sometimes these abnormalities can last weeks, if not months. And so this is a baby who had staining. Look at the green teeth, right? He has green stained teeth from congenital hyperbilirubinemia that lasted a couple of months from congenital syphilis. This is not an HIV-infected baby, but just the dramatic presentation, right, with this prolonged conjugated hyperbilirubinemia. And just another, what's going on here in terms of the pathogenesis? Mo, I'm just reiterating what you've already said, but there's probably, you'll notice that the liver enzymes, the hepatocellular enzymes rise after beginning treatment, right? So it may be Jarisch-Herxheimer-like reaction to the toxic products of the spirochete lysis, with infiltration of the liver with macrophages. There's a CD68 positive stain there in a case report from the literature, followed by fibrosis. So you do see these markers of fibrosis, which may explain the prolonged the prolonged cholestatic picture that can again last weeks to months. So I just wanted to mention that as an interesting follow-on to what you said, Mo. And I think I did have a few. I'm going to perhaps skip over this, but we did struggle with hematologic toxicity and a similar question about AZT, right, which causes hematologic toxicity. But let's skip over that one. And just to mention quickly that. And then quickly to mention that we had to decide on prophylaxis. And at 4 weeks of age, we began atovaquone and azithromycin for PJP and MAC prophylaxis, respectively, because his CD4 T lymphocyte count was right on the borderline of what you'd need for, what you'd call immunosuppressed for a neonate. And so that's the case. And so complicated management because of the congenital syphilis that threw us all kinds of curveballs. And his current status, he remains in ICU as of today. He's improving, though, much more stable. We're planning to follow up on the syphilis RPR following his HIV infection. His respiratory support, he's still on some caffeine for apneas of prematurity and on some high flow oxygen, but his lung status is improving over time. Thrombocytopenia and anemia have improved. He required multiple transfusions, but now seems to be stable. He's got the retinopathy of prematurity, some bilateral inguinal hernias as complications of his prematurity. And unfortunately, the social situation is dire. The mother has psychosis and substance use disorder, and so he'll go into the foster care system in Canada.
What did you do with nevirapine?
We're thinking of with respect to the nevirapine. We've still got him on the nevirapine right now, and We didn't want to rock the boat too much in this unstable kid, so we continued what was working.
And to me, just to say, so the online audience were 100% against switching the AZT to a back over,
Oh, yes, we don't like that.
as that's an option now. So I think it's so we over time, but I think really, really great cases. So thank you both to Sibu and Michael. Again, I think just highlighting the difficulty with treating these complicated patients, and it does require really a community of people to come together to come up with these answers. And to our panelists who had been abused with and we had to ask them difficult questions on the spot, we thank you as well. So thank you very much.